Hi guys, my name is Vedantham. Some of you may know me from the MSc Reserves for the SIR. It's my privilege to be hosting our fourth webinar with the RFS and the MSc. Today's webinar is a little special to me. It brings me immense joy to introduce our speaker, who's going to be talking about something that we feel is very important in the realm of interventional radiology, and that's clinical trials. He has many titles. He's a professor of radiology and surgery at Mallinckrodt Institute of Radiology. He's the assistant dean for clinical research, medical director of Center of Clinical Studies at Washington University at St. Louis. He's the national PI for the C-TRACT and C-TRACT trials, but I know him personally as my mentor, a role model, and frankly, a source of inspiration for what I'd like to be doing with my future career. So without much further delay, I'd like to introduce the speaker for tonight, Dr. Suresh Vedantham. Thank you.
Well, thanks very much, Siddhant. That was very generous and really great to see you and then to have a chance to be with all of you today. I'll be talking about a topic that's near and dear to my heart as well, the effective IR clinical trialist. I should mention there was a disclosure slide here that seems to have fallen off, but basically I receive NIH grants and one company, Medi USA, donates compression stockings for a study that I run. So the objectives of this talk summarize the realities and opportunities of kind of improving your abilities as clinical trialists, convey how to think about becoming an unbiased investigator who can develop good study hypotheses and apply hands-on implementation expertise to clinical trials, and really to encourage you to be willing to put the effort in to disrupt our current culture in IR to kind of pursue a sort of improvement process to foster the primacy and the acceptance of evidence-based medicine within IR. It's going to require a lot of effort from a lot of people, and I think that you all can really be at the spear of that, at the tip of that spear. So first I'll start by just talking a bit about just general considerations regarding entering research and clinical research as an IR investigator. I think the first thing to realize is that, IR, I will say it over and over again, it's the greatest skill set in medicine. Just the range of things that we do, the way that we interact with the human body are truly unique compared to any other field, but having said that, I think historically, most trainees really view IR maybe with a more limited sense of what it can be than what it truly can be. I think it's important to realize that there are interventional radiologists that run basic science labs. There are people that work on, applying their imaging skills to develop new devices and startup companies, participate or lead clinical trials or clinical trial organizations, administrative roles. There's just such a broad range of things that an IR can do. And I think that looking at yourself as someone who has the potential to really differentiate in many directions is very important. Most of us start out as focusing on our clinical expertise and specializing in a particular area that provides a foundation from which to start researching things. I'll mention, some of you know, I'm the PI of the C-TRACT trial that was completed a few years ago. And just by way of introduction, my career trajectory was very unusual. I became kind of a clinical expert in venous disease. That wasn't unusual. But what did evolve is that I began to lead this effort to develop a clinical trial. And in the course of putting in the energy of leading it, if not the expertise at that point, I began to be seen as the leader in moving things forward. Even though really, quite honestly, I'm trained as an MD, don't have any special research training, a lot of motivation and desire, I guess, but really a lot of it came because of the energy, I think. Once I got the C-TRACT trial funded, running a large kind of coordinating center for a large multi-center trial, within my institution, there was another investigator from another department that wanted to run a large multi-center trial in a totally different disease area, lung transplantation. And he went to the university and they didn't really have a great way to accommodate him or support him, so they sent him over to me. And we've been running his multi-center study now for several years. From there, I was asked by our hematology chair to be his co-director of a translational research center in thrombosis funded by NIH. And then from there, I moved into research administration as an assistant dean and doing all kinds of different things. And there's also been national roles that I won't really bore you with. But the bottom line is that that evolution came in a very much a stepwise way in ways that I didn't appreciate fully. So going back to the beginning, though, I think that the first thing is to pick something to study that you're actually really passionate and care about. We all explore different directions, especially during our training years. Gets us to meet different people, gets our CVs to look better. But in terms of really trying to make a dent and accomplish something in an area, it needs to be something that you really care about. My own kid, when he's talking about technology, Harry Potter, or drums, and back when he was 7, snakes, as you can see here, is the smartest person in the universe. He's a wonderful kid in a million ways, but that doesn't apply to everything necessarily, right? When you're really passionate about something, you just do better at it. Research involves work. Don't be surprised at the fact that your clinical leaders are not necessarily entirely sympathetic or understanding or knowledgeable about what it takes to do good research. You're going to find that you do spend your own free time doing it if you want to really get anywhere in the field. And so I just think that willingness to learn and grow and that commitment to it is a big part of success. I think it's very important to understand the realities of our culture in IR. Remember that most fields in medicine, they do clinical trials as a matter of practice, and that's how they advance care. But interventional radiology is a lot more like surgery, where you have word-of-mouth transmission of wisdom from generation to generation. We share anecdotes with each other, and from there we get to consensus. And we factor in evidence a little bit, but there's very few high-quality studies in our fields. It's also harder to do large clinical trials in procedural fields, right? And so in some ways, really our role in the system has been to individualize the use of technology and imaging-guided procedures and devices to treat medical problems in a very person-specific kind of way. People talk about personalized medicine now, but quite honestly, that's what IR has been doing from its inception, really, is adapting tools to meet the needs of patients and their providers, right? But then again, that puts us at a vulnerability when it comes to large clinical trials and trying to advance through evidence and trying to be objective, right? I think that we have an inherent bias towards thinking procedures work most of the time. We're pretty resistant to believing otherwise, even when told by very quality information sources. If you think about the way that we operate, our practices, our organizations have a very close relationship with the medical device industry, and that also colors the thinking as well, right? And we're not immune, and we're not alone in that. Our medical colleagues have very close relationships with the drug industry, right? But then again, these things obviously can bias and skew thinking, and it's very important to try and figure out how you can internally get past that. The other thing is that we really don't have adequate training pathways in interventional radiology. Some of you, this course, this offering right now is intended to try and remedy some of that, right? But very few of us are formally trained in research. And that makes us, in addition to less able to do more complex research, less aware even of the resources that are out there and of the grant opportunities that are out there. So I think one thing early on is to take research education seriously, realize that being a great doctor is a completely different thing from being a great IR practice builder, and that's a completely different thing from being an effective clinical researcher. These are completely different skill sets, and to be good at the third thing, you've got to focus a little bit on that third thing. Some of the other barriers to be aware of, remember that priorities in radiology and interventional radiology are as I've listed them at the top of this slide. Clinical volume over quality of care. I wish I could say otherwise, but I would say maybe 25 years ago I'd say otherwise, but nowadays we see what the healthcare system has sort of become. Over education, and then research is kind of at the bottom in interventional radiology for sure. Some of that is that most of our leaders don't really have research training backgrounds themselves. If you become a chair of a department of medicine, almost certainly you were an NIH grant winner. It's almost impossible to become a department chair. And to some extent that may be true in radiology, but it's not quite the same, and certainly not in IR. In IR, most people come from a more clinical pathway. Some were program directors, etc. Right? So the level of insight and what it takes to be a researcher isn't quite there. And then secondly, there are pretty strong financial disincentives to do the highest quality research, NIH research. The bottom line is that just because of the way radiologists are compensated relative to other fields, when you go and do an NIH study, that means your institution is going to have to pay a bit on their own to support that activity, and that causes a challenge as well. All of that results in not really necessarily the greatest reward system if you're going to be doing high quality research. It's also important to realize that for clinical trials, there is a long distance, of the IR from most patient populations, right? We may see a referred population, but overall, most of the patients with the diseases we care for, their general patient flow is somewhere else until they get referred to us. And connecting that distance, crossing that distance, is important if we want to actually succeed in enrolling people in the clinical trials. We also aren't usually the central voice in determining a patient's care. Now that's changing a bit, and certainly there are many diseases in which IRs have evolved into the primary voice, but having said that, that's often not the case, and so this is going to involve dealing with other providers, succeeding well. And then finally, we tend to be unaware of institutional resources. We're mostly aware of what's available in IR. We're somewhat aware of what's available in our radiology departments, but outside that, many of us are in large institutions that have an awful lot of resources and support for researchers, but we're totally unaware of it, right? So it's very important for you all to really take on a posture and a mindset that you're willing to collaborate and that you're willing to reach outside your radiology silo, in a sense, to find other people who can lead you in the right direction. But now I've said a lot of things that kind of maybe are a little bit sobering, but I do want you to appreciate most of all the incredible benefits of becoming a clinical researcher. The first thing is that you'll provide better patient care because the level of scholarship you'll have to engage in and the kinds of collaborations you'll have to engage in are just going to make you so much more knowledgeable and insightful about all aspects of a disease process. The second thing is that you have an opportunity to influence the care of many, many more patients than just the ones that you see in your own clinical practice. That's pretty cool, really. And then finally, and I say that in the sense that, there are people that contact me on a daily basis from Australia, Africa, Asia, with questions about their patients, right? That's just kind of a crazy thing when I really think about it, And then finally, there can be opportunities to contribute at a higher level in terms of, for example, governmental panels and organizations and things like that. So a lot of opportunities here. So how do you get there? I think the first thing is to conceptualize research as you're there to find the truth and answer a question. The study is there to answer a question, right? And the foundational belief that you're pursuing is that, truth matters and it matters to patient care, and we don't know the answer, and that's why we're doing this study, right? If you go into a study with the idea that you're there to prove A or B, as opposed to sort of learn if A or B is the case, you're going to be biased, right? And you're going to reduce your ability to find the truth, right? The whole idea here is for patients to get the best treatment, and to do that, we have to appreciate that even if I have a hypothesis that seems like it makes sense based on my clinical experience, that could be totally wrong. And that's very important because we're often testing new paradigms of care that really are the subject of very little evaluation before we came on the scene, right? So it's very important that to be a good investigator, you have to train yourself to be objective. None of us are free of implicit bias, but we need to learn as an investigator. It's a process of disciplining yourself to overcome your own implicit bias as much as possible. That is the kind of the mindset you really need to have. And when you're doing studies, remember that you are the leader of the study as the PI. Your collaborators are going to follow your lead. So the more you can talk in an unbiased way, the more they will also behave in an unbiased way and give you the best chance of finding truth in a particular study. The biggest challenge, I think, to doing that is the fact that any subspecialty has what I would call a groupthink that derives how it thinks about diseases in areas of controversy. And that's influenced by the whole way in which we learn about a disease, right? And just think about, I think about the disease that I care about, deep vein thrombosis, right? Well, your emergency room physician sees patients with big swollen legs that are hurting, right? And has a certain part of the patient's care that they deal with. Then the patient gets sent out and they don't ever see him again, right? No emergency doctor has ever seen a wound on the leg due to post-thrombotic syndrome. That's just not the right provider, right? Another physician, a hematologist, doesn't see the patient until 6 months into their care, and somebody's asking, how long do I continue to anticoagulate him or her? And then a surgeon or an interventional radiologist only sees the selected subset of people that got a lot worse and that are the most symptomatic, right? And from there, we're trying to draw extrapolations to the entire disease population. And that's really, you have to be very careful when you start to do that, because the population that we see oftentimes is not the population that other providers see, right? The clinical setting is different as well. I mentioned about, you know, the industry, the effective industry already. And then also you just got to think about egocentric interests, right? We all want to believe that what we do works, right? And when there's a nail, if you have a hammer, you tend to want to see everything as a nail, right? And so you have to always think that there are lots of reasons why it's easy to become biased, and that a lot of that bias is not conscious, it's subconscious, okay? And, you know, when I think about grant writing, for example, if you want to write NIH grants and things like that, you know, you can tell when somebody is ready to get funded, because the way they talk about their study is that they can argue both positions, positive or negative, very convincingly, you know. Then you know you're kind of ready and thinking about the question that you're asking in the research study. When I think about DVT, I mean, it's fairly appalling to me, some of the groupthink that we have out there. First of all, just think about the language, you know. I mean, like an interventional radiologist, we think about the anatomic blockages, right? And the physiological malfunction with the venous valves, for example, right? A hematologist views thrombosis as a condition of the human body whereby the whole body is more prone to clot, right? They don't talk that much about the location of clot. They talk a lot about the body's predilection to clotting. What are the factors that promote clotting? Which ones are reversible? And how does that influence the anticoagulant therapy they're going to give? We use terms like valvular reflux or stenosis or iliofemoral to denote these anatomic distinctions. They don't really even know what those are. They talk in terms of the reason the DVT formed, an unprovoked DVT, or whatever, terms that we don't use quite as often in our field, right? We see venous ulcers all the time because people get referred to us with the worst disease. A lot of hematologists I know, remember, hematologists manage DVT better than primary care doctors do because they're specialists, right? A lot of these people that I've talked to say, well, I've never seen a venous ulcer, you know? And similarly, we talk about anticoagulation and its limitations because we're dealing with that late stage patient that didn't do as well, whereas others look at this and say, how the hell can you poo-poo anticoagulation, which has been shown to improve outcomes in this condition for many years? And when we talk in those ways, we make ourselves fundamentally less credible, and it's harder to get collaborators to do good research, right? Think about some examples, you know, May-Thurner syndrome, for example, right? We made the observation that after we lyse DVT, many patients have a stenosis in their iliac vein, like the one that you see here with all these webs. This is an iliac vein, and here's a tight stenosis with a crossing artery. You can see that negative filling defect there of the common iliac artery crossing. And we have extrapolated from that observation. We've also observed that if you don't stent this thing, that people rethrombose. But remember, that was in the context of us messing around and intervening and revving up the clotting system, right? We concluded from that May-Thurner syndrome is an independent risk factor for DVT, which is completely unjustified and not really supported by any epidemiological study. We've equated stenosis with thrombosis, but these are two totally separate biological processes. And we've kind of convinced ourselves that all these lesions need to be stented, which puts us in the position of putting permanent devices into people, maybe even in situations when it's not needed. In the lysis situation, yes, you've revved up the clotting system. If you see a lesion like this, yes, it does need to be stented. But in many other situations with the stenosis, it doesn't really need to be stented, you know. So there's a lot of hazard involved when we don't quite understand the disease process. And the examples can be rampant. You know, we've said for many years in IR that everybody with iliofemoral DVT gets severe post-thrombotic syndrome. Well, it's a lot, you know, maybe about 20% get moderate or severe post-thrombotic syndrome. And we know that from prospective studies. But remember, we've made our observations in that referral population that happens to be more severely affected, right? There was an initiative years back to encourage people to go get your varicose veins treated because varicose veins are associated with DVT. So we're scaring the daylights out of people, right, to go get their veins treated, right, for no good reason, right, which is not really a fair, honest thing to do, right? And then right now we're in the midst of a rapid growth in pulmonary embolism treatments that are very exciting, but on the other hand, we're basing them on these single-arm studies with no control groups. And so there's really no evidence whatsoever of any clinical benefit yet. Certainly this is promising, but there's really no benefit shown yet, and yet we're diving ahead and doing a lot of it, right? So these are very, very important things. A big part of the lateral problem is that appreciating the fact that most people survive with the submassive PE with anticoagulation alone. We don't talk in those terms, right? The death rates in clinical trials are 2%, right? But you don't really hear a lot of IRs mention that, right? So these are very important things. What are the solutions? Well, first of all, scholarship. People don't talk enough about this, but honestly, you got to know the disease, and that means reading the IR literature, reading other fields literature, interacting with the broader range of clinicians. And my mentors, I see a bunch of them. You see a bunch of them up here, some of whom are from interventional radiology, and some of whom are thrombosis leaders, cardiology leaders, surgical leaders, etc. So multidisciplinary education is important. Training in sources of bias is important, and I'll mention some of them later in this talk. And when you get that, you learn how to communicate with physicians of other fields, and then you're able to become a better researcher. It also enables you to talk to patients better. You consent patients in a much more refined kind of way, and if they're in your clinical studies, it's a lot easier to keep them in your studies because you're talking in a balanced way. I think that sometimes it's not easy at all to collaborate with people who have a totally different mindset and philosophy. And I remember back in 2004, the CHEST guidelines pretty much utterly dismissed thrombolytic therapy for DVT. They said only for these people whose legs are falling off, basically. And I remember having to work with a lot of the people that developed that guideline and developing the ATTRACT trial. It wasn't easy at first, but ultimately you start to appreciate the perspective, and then you can do so much better in your study design, in the feasibility, because you need them to help get the study done. And then at the end of it, the overall impact as well. You have a lot of people bought in. Finally, my last comment for the general considerations is that, I think you can build a reputation as a great mentee by being dependable and organized, and in particular, communicating frequently with your mentors. I think that when things aren't going well, or when you choose not to follow someone's advice, it's tempting to feel awkward about it and not communicate. But I think that's one place where you really should communicate, because it really tells the mentor that I respected you enough to tell you. And two, I took your advice seriously and thought about it and considered it and came to another conclusion, or whatever, So checking in so that they could see that you're responsive to them, nothing is more rewarding than someone who's a little bit responsive to you, right? Whereas if you feel like you're not having any impact on someone, that obviously reduces motivation, And again, I've been so lucky to have so many incredible mentors. I'll talk a little bit now about just preparing for implementing trials. Again, the most important thing to realize is that when you do clinical research, you are trying to do an experiment, a lab experiment, in a non-scientific environment, okay? The clinical world is chaotic. There's lots of agendas, lots of busy people, right? And the first and worst fallacy is when you write a study protocol is that the world is going to align itself to your study. That's not the case. You need to write the protocol to align with the real world. And the first thing is to understand the people in the real world, right? And understand that you've got team members and other stakeholders, right? You want to overeducate them about the issues in the study. That's the best way to improve quality, is generally education. You want to over-communicate, thank them, provide feedback, let them know about progress, because that's what helps them see the sense of active motion and want to be involved and continue to be involved. And then you want to thank them for their time, their energy, their expertise, their political capital. You need all of it to get quality studies to succeed. Everyone's got to feel part of that, right? You want to consider the fact that your coordinator, your research coordinator, is going to be a very important person on the team. And remember that that person is not just there to implement what you say, but also to bring his or her expertise into the equation. Remember that coordinators undergo training that involves regulatory issues, documentation issues, and these are things that do need to be followed when you do clinical research. And their job is to look at that study protocol, and knowing that doctors often want to do whatever doctors want to do, and rein you in sometimes and say, wait a second, but the protocol says X, and that shouldn't be viewed from your perspective as some type of pushback that's inappropriate or disrespectful. It should be viewed as, we do need to follow the protocol, so we need to sit down and talk and resolve this, right? That's an important issue. But the bottom line really is that you need to be communicating with your study team, and in particular the coordinator, frequently. so that you can really resolve issues and become a better team. And in all the studies I've been part of, we didn't start out succeeding. We wound up succeeding, and that's because we gradually improved over time. You want to understand the value proposition of your study to all the stakeholders involved. So think about the patients. What's in it for them, right? It could be different things in different studies, right? Sometimes they get access to a new procedure or device or treatment that they wouldn't have gotten otherwise. Sometimes they get free items in the study, free visits, free ultrasounds, free drug, free whatever, right? Sometimes they just get the benefits of being part of a structured care process, right? The communication and collaboration that your study team can provide, right? But you need to explicitly ask yourself that question before starting. Because when you go to consent somebody, right, you can't be just thinking about the question that you want answered. You need to be thinking about it from the perspective of why would they want to be in the study. Similarly, from the perspective of gaining collaboration with their providers, why would they want to refer a patient, right? If it's easy to refer patients, if the patients are well cared for in the study, then the provider may want to do it. If it's challenging or painful or difficult, or they feel it inconveniences their patient too much relative to the benefits the patient gets, they probably won't, right? But again, you want to think about it and think about the diversity of providers. Who actually sees my DVT patients, right? Well, actually, it could be an ER doc, it could be a hematologist, it could be a primary medical physician, it could be a surgeon, and I got to think about each group, right? And if I'm going to do clinical research successfully, I need to understand what's in their minds, right? You want to think about, do your university or hospital or department benefit, and don't assume they're the same thing. The hospital is an institution that's there to provide clinical care. The university tends to care more about research and clinical studies and all that. These are very different things, right? And remember that the hospital staff, they're not paid to do research. They're paid to take care of patients. So when you're doing a study and you're trying to figure out, and you're expecting things to happen in the course of clinical care that rely on hospital personnel, let's remember that you're adding a burden to their job. Their job is not to take care of your research study. Their job is to take care of their patient, right? So it's on you to figure that out and make sure that you communicate with the hospital staff and make sure that you do what you can to minimize the burden there, right? There could be benefits and collaboration even with insurance and payers to get them to pay for things in studies if you think that your study could be of value to them down the road. And you want to just ask yourself, who else exists that might care about the study that I'm going to do? Again, you want to make your study clinically friendly. Consider the daily lives of your patients. If you're saying that you're enrolling, people who have uterine fibroids, let's say, which is generally speaking, fertile age female population, right? That are going to come in and get 6 hours of MRI testing and other exams during the course of their day during the school year, when maybe they may or may not have to pick up their kids afterwards or whatever. I mean, you got to be realistic about the burden you're applying to different kinds of participants, right? And consider their daily lives and how you set up your study. If you're expecting them to come back every 2 weeks for a follow-up visit, that's just not realistic. They're not going to stay in that study. They're not going to want to join, right? Similarly, with clinical personnel, as we talked about, don't underestimate the fact that, you got to think about the weekends and the evenings. If your study is expecting to enroll people at those times, you got to think about any specialized services that you're trying to work with, intensive care unit, emergency department. They have their own issues there, right? That are very complex. The emergency department is trying to move people in and out of there very quickly, right? The hospital has bed crunches. The ICU has bed crunches and a lot of sick patients, right? So there can't be a lot of holdup because of a research study, right? But the point is that you want to be thinking proactively about it so you can go and engage those nurses and physicians and get their support, hear their concerns, and figure out ways to address them, right? And then finally, in your protocol, you want to write the protocol not to be overly proscriptive. You got to consider what you can realistically control, right? And write the protocol to be flexible enough that people can provide care in the best way possible. And so, for example, in my studies, pretty much all the patients get anticoagulation, right? It would be ideal to standardize what drug they got, right? But here's the thing. I don't decide what drug my patients get with anticoagulation. Their insurance company decides. So I could say everyone's going to get Eliquis, right? Unless I can provide that Eliquis and deliver that Eliquis to them, it's totally unrealistic to say they're going to get Eliquis, it's better to just say that, you know, they're going to get anticoagulation. We strongly recommend Eliquis, but it's up to you, right? Then people can actually do the study, right? That's just one example, but there's lots like that. And the key thing is that you can use words like encourage and discourage in a study protocol as opposed to must and should, to allow things to happen and kind of make sure that you don't box yourself in getting a study done. I think the investigator needs to convey a pro-enrollment mindset. Recruitment is very complicated, and it's the #1 challenge to getting studies done. Remember, clinical studies throughout the US, right? Large-scale data has been looked at in this respect. Only 1/3 of studies end up recruiting their planned target. And 1/3 of sites don't end up enrolling a single patient, okay? So recruitment is the huge bear, really, that is very difficult, actually. And it's even harder for IR studies because, one, you're dealing with procedures, so surgical stuff rather than medical stuff. Secondly, you're often trying to compare procedures with another form of therapy that is much less invasive, or if it's surgery, open surgery, much more invasive, right? And so getting people comfortable around the idea of being randomly assigned, that's pretty challenging, right? And then thirdly, we are distant from where the patients flow in many instances, right? You know, my DVT patients, for example, they go to the ED, they go to the vascular ultrasound lab, and they're gone. You know, they're just gone. They're not in the hospital, really, you know? And so somehow I got to find a way to connect myself up to where they are, right? And that's true in lots of areas of IR, right? Think about interventional oncology. You know, you've got the challenge that the cancer patients flow in their own ways, and we get referred a particular population in whom we do certain interventions. And usually when we get referred those patients, there's some sense they might need that intervention, right? In addition, don't forget that the oncologists are doing literally 1,000 other studies in the same disease process, and they have a lot more of an incentive to enroll to their own study than to your study, right? So you have to collaborate. You have to be creative. You have to think proactively about these kinds of things. A PI really needs to be open to hearing diverse inputs from different people to get guidance on how to successfully enroll patients. Don't forget that in addition to just the disease area, there's a large body of recruitment science that has been published on what are the best practices in consenting people, for example. You know, these things actually exist, and I have actually reviewed them in the course of doing the C-TRACT trial, and they were inordinately helpful in trying to ultimately get the study done in the end. I think it's very important for you as a PI to be kind of empathic, right? You need to really have insight into the value proposition from different perspectives. You need to be hands-on in monitoring enrollment and determined to succeed and share what you've learned with your collaborators. I think a written recruitment plan is very helpful in forcing you to consider the study as kind of a multi-dimensional challenge and think through all aspects of recruitment challenges. It helps you communicate with collaborators as well. And again, depending on the study you're doing, C-TRACT was a large multi-center NIH study, so we actually took the time and created a formal 20-page manual that we provided to all our sites, but I think even in other studies, a one-page summary of best practices could be a great resource to provide to your collaborators, right? And that's very important, right? And for example, the simplest thing, right? In a study I'm doing looking at venous stents, right? Sell the study, not the stent. Because I'm trying to get people to be randomized, right? I want people to be excited about, about the study and being part of a program and accept the idea that they'll be randomly assigned to stent or no stent, right? Well, if many providers are already skewed towards stenting and they're trying to sell the study by selling the stenting, these are not people that are going to be randomized, right? So for example, these are things that you want to think about in advance so that you can educate your collaborators on how best to address these challenges. I think recruitment has different dimensions that need to be analyzed separately. There's the issue of identifying patients, right, and connecting them to the study team. And you need to consider, okay, is my study looking at patients that are in the hospital, or is my study looking at patients that are out in the world, right? If it's in the hospital, then focusing on getting internal awareness within the hospital system with key collaborators is the most important thing to do. If they're outpatients, then the most important thing to do is probably going to be getting the word out there in different ways using whether it's informatics tools, social media, practice-based networks, other referral providers, etc., right? The strategies have to be different, right? Secondly, eligibility determination. Again, it's important to take an inclusive posture. Again, you're trying to have a generalizable study, so you don't want to be cherry picking patients. You want to be inclusive in terms of anyone that meets the eligibility criteria should have a chance to enroll with rare exceptions. In terms of consent, you should be tracking the rate of consent, how many people are saying yes or no, and understanding the reasons why, because that's going to help you refine that value proposition and learn better ways to approach patients. And then you need to think about the other issues, right? There's lots of issues that relate to costs, travel reimbursement. Okay, if you're saying that you're going to provide them reimbursement for their travel to the center, make sure you do it in a timely fashion. You want to think about issues specific to underrepresented populations, minorities, women, etc. Again, you want to be looking at these things on a regular basis to succeed. I talked a bit about eligibility determination. The key steps here, I think, are that your protocol needs to have crystal clear eligibility criteria written that are very specific. You need to take an inclusive posture, meaning, again, people often apply their own, they make up their own exclusions. Oh, well, you know what? I think he'll be less compliant and therefore I'm not going to enroll him. Well, what you often are really saying is that, they're from maybe an area of town that's not as reliable, they can't get a good transport, or the patient has poor socioeconomic status, or whatever it is. But the thing is, these treatments are going to be utilized in those populations as well. Therefore, it's important to have those people in the study. And in addition, they should have every bit the right to be offered the opportunity to participate as any other patient, right? So if they don't meet an exclusion criteria, really you ought to be trying to offer them participation in the study, right? Now, along with that goes the burden of being honest about the potential costs, right? So the point I'm getting at is not that you should hide the costs or the risks, but that you should be transparent about the costs and the risks and allow the patient to make the choice whether or not they want to take those on. It's also important to track what you're doing. And so, for example, monitoring, using a screening log to check off, what criteria do they meet to not be enrolled, And this is important because it helps you understand where you're losing patients. Should you modify the protocol, or is it that some sites in your study just aren't understanding things well? And maybe you have to write things more clearly, right? And these are very important in helping us understand that. We always have a box at the bottom here that says eligible but non-consenting, so we can track what proportion of people are actually getting consented versus not. And that way we can understand if it's part of the problem that the study is either unattractive to patients or the people are just not presenting the value proposition properly, right? So again, there's no such thing as a quote perfect patient, meaning suburban, well-off, compliant. You want to get all patients in a sense that would qualify, right? Okay. Consenting patients, remember a few things that research shows. And again, there are people that have PhDs and devoted their whole career to looking at this stuff. Professionalism equals trust to a patient. When you dress well, they appreciate it and they trust you more. And studies have shown that recruitment rates in clinical studies are better for men when they wear a suit. I don't think that most of you are going to do that, but that's better than wearing a shirt and tie. And that's better than wearing other things. Wearing a white coat actually reduces recruitment rates a little bit because patients are afraid that you are like a lab researcher and they're a guinea pig. Wearing scrubs terrifies them. They're absolutely terrified, and it markedly drops recruitment rates. And I learned this halfway through the ATTRACT trial. And from that point on, my coordinators will tell you and will laugh about it, but I keep a shirt and tie in my office. When I go to participate in the consent process, I change out of my scrubs, and these are practices that we encourage throughout our network, People do tend to trust women a little bit more than men on average. Again, it's maybe around maybe a 5 to 10% absolute difference, again, on average. That's true for both genders. And people tend to have higher trust for same race or ethnicity, and that's especially so if that person stops by a second time. It's important to orient a patient to what research is. Don't forget, when you start talking about a study, you assume a certain amount of health literacy in your patients that they may or may not have. So the way that we start would be to say that, as you know, here at Washington University, providing outstanding clinical care is a high priority for us, and as part of that commitment to great care, we participate in clinical studies that we think will be good for our patients. And that links the study to your institution's reputation and also tells them what the study does. We say research studies help doctors learn what tests and treatments work best for patients. Something very simple like that, right? And even then the patients that really aren't that literate and maybe not that well educated will understand what the study is, right? And that's a very important part of starting. And again, starting that way has been shown to improve recruitment rates in clinical in research. And then finally, at the end, a physician's recommendation to participate has also been shown to increase success. So hopefully you'll be comfortable in recommending study participation. Again, just to be clear, non-coercively, right? You're providing a recommendation, but they're making the choice. Again, conveying, some of the key advantages of being in a study: patients are closely monitored. They can help others and receive an outstanding level of care. They get access to a study team. Sometimes they get free items, and the protocol has many safeguards in place. You can talk about those as ways to encourage and boost the study. Clinical equipoise is a big problem in IR studies, right? We tend to believe in our procedures, right? But the hazards of, the fact that people may apply their own selection bias and prevent people from getting into the studies, those are big hazards. It's not just a matter of the number of people enrolled, but it also affects the composition of the patient population that's in the study, and that affects the results, right? So for example, here's a patient who's 21 years old with obvious May-Thurner Syndrome, a big left acute iliofemoral DVT. From my perspective, this is a slam dunk for catheter-directed thrombolysis, right? But if during the ATTRACT trial I had said, we're not going to enroll this patient because there's no way I'd feel comfortable putting her in a control group, well, what I'm doing is I'm essentially taking the best patients, the ones most likely to benefit, and I'm taking them out of the study, right? Well, then the study is going to be more likely to come up negative, even if there is a real benefit. Similarly, if I take the 75-year-old man with the smaller DVT, and he had, other issues, medical issues, and I say, well, you know what, I'm not going to enroll this guy, Well, again, the problem there is that then I'm going to underestimate the potential safety downsides of the study, right? By taking out these kinds of patients, right? And then the study, when you're done, you get a result and it looks great, and you apply it to 100,000 people, and then you start seeing the safety issues, right? That's no good. The whole idea is to see stuff in the study so that you can help people after the study, right? So this is a very important issue in IR, and it really involves training ourselves how to talk in a balanced way about the procedures that we do. Retention is also important. The key thing, I think, is to keep your promise to deliver value to the study, to the patient, I should say, right? You tell them up front, we're going to coordinate your care, you're going to communicate with you, we're going to help you, we're going to reimburse your travel. Well, if you're going to say those things, do those things during follow-up, right? Help the patient, meet them at the front end, have your coordinator meet them at the front entrance. Bring a wheelchair if it's a disease that if they can't walk, make it easy for them. The idea is the patient is saying, it's easy to help the study. And their doctors are thinking, you know what, this study is good for my patients. That is what you want to kind of build, right? One thing that's important also is show interest in the whole patient. My coordinators know the birthday of every child of every patient that I've ever enrolled in a clinical study. They're just so good with that stuff. And that is why we've been so successful in our clinical studies. In terms of design, again, the outcome measure, the primary outcome measure is given a lot of importance because that is the measure around which you build your sample size and around which you build your protections against bias, right? You try and standardize confounders that may influence that one outcome, right? So again, it should reflect clinically important disease. Ideally, it should be well accepted in the field. You should try and make sure it's objectively accessible. And if possible, or if it can't be, just say it's patient reported, for example, it can't be totally objective. You should try and find other ways to minimize bias in the protocol. If it's a measure, as in like a scale, there are standards for acceptability, reliability, validity, responsiveness to change that all support its use. You want to go through and review if it really makes sense to use this measure for this condition. And then it needs to be statistically testable because that primary outcome measure will be used to determine the sample size, Bias is very important for a leader of a study to exhibit a sensibility towards. Again, you're going to design your study in a balanced way. Some different tools that can be used there. Randomization and eliminates selection bias. Often, you want to use generally an intention to treat thinking. In other words, if they sign up for the study and they actually enroll, you're going to report their outcome at the end, no matter what happens to them, unless they explicitly withdraw their consent to be followed in the study. So if they die, if they get excluded for some other reason, you're still going to be transparent about reporting what happened to them. You want to avoid crossover. That's something that can undermine IR studies quite often. You randomize them to a control group that doesn't get intervened on, then 2 weeks later their symptoms are bad and you want to intervene on them. Well, that's going to screw up your study pretty badly, right? So you need to think about that in advance and plan for it. You want to standardize your assessments to reduce bias. And to the extent possible, you want to blind the assessors of clinical outcomes, the adjudicators of clinical events, if possible, the patient's providers, and even in some situations, the patients, as to which treatment arm they're in, if it's a comparative study, to give you the best chance of an outcome assessment. That's unbalanced. The FDA has concluded that in open label studies that don't have a placebo, that fully 1/3 of treatment effect can be explained simply from patient reporting bias due to the placebo effect, okay? So these are very important things. When you go and intervene on a patient and talk to them afterwards, they often believe they're better. Sometimes they actually are better. Sometimes they're not, Okay, last thing. I'm hoping I can enlist you all to really be vocal advocates to transform the culture of our field. As you know, we've done this C-TRACT trial, which was a large NIH-sponsored 700-patient trial looking at patients with DVT, obtaining or not obtaining catheter-directed thrombolysis, and we published those results a few years back. This was a huge 15-year effort, supported by the SIR Foundation up front, actually, so they should be very proud of that. And the neatest thing about this that I really want to convey to you is just how much impact these things have. People complain about the results all the time, but the impact is just inordinate. The one slide that probably depicts the study's results more than anything else would maybe be this one, where we have characterized the natural history of this disease process by whether or not the patient got lysed or not. This is the change in their quality of life from baseline. And as you can see, the middle two lines are people that have a smaller DVT in just their femoral and popliteal veins. And there's really, these two lines are people that were lysed and not lysed, the green and the black here. And there's just no difference through 2 years of follow-up, right? The blue and the red are people with iliofemoral DVT, larger DVT involving the pelvis or common femoral vein. And you can see here, there's a substantial difference between people who are lysed and not lysed in their amount of change in their quality of life in the first 6 months. Between 6 and 12 months, there's some catch-up that occurs. And then after 12 months, there's still a difference, but it's substantially smaller. This type of thing is so important because now when I go and talk to a patient about the risks and benefits of lytic therapy, what I can tell them is based on evidence. And what I can tell them is that, look, you may be better in the long run, but there's no guarantee of that. But it's very likely that you'll be substantially better, and your recovery of your pain and swelling will be much improved in the first 6 to 12 months, and you may also achieve a longer term benefit. But I don't hit that one hard because the data supports the presence of, on average, a relatively small benefit, right? So I think that this kind of information is so important in the way that we talk to patients, You also learn so much more about the disease natural history. I think even just going back, just think about this. This red thing here is the disease natural history without lysis, right? And we've characterized that people are still improving out to 12 months. And that's important because I get referred people at 5 months and 6 months from their DVT, right? And I'm thinking, should I jump in there and intervene now or not? Well, now I think I would say that, it's probably better to wait a little bit, right? And see if they improve to the point where their life's tolerable before I go jumping in and dropping permanent devices in, for example, right? So these are just very important in understanding the natural history of the disease, right? We also found that the procedure result, the amount of clot at the end of the procedure, did not correlate with whether or not they got the post-thrombotic syndrome, which was utterly perplexing to us, right? As you can imagine, right? Now, it was a little bit different for people with iliofemoral DVT. We found actually that the severity of their post-thrombotic syndrome did correlate with the amount of thrombus that was remaining, but not for other patients with proximal DVT. So that whole open vein hypothesis didn't seem to apply in other patients. In our 1-month follow-up, we found that, again, this is pooling people who were lysed and not lysed. If you had an open common femoral vein, you were less likely statistically to get the post-thrombotic syndrome, to get moderate or severe post-thrombotic syndrome, and to have better quality of life. So in other words, an open vein does matter if the vein is open at 1 month, right? But then early on, having the vein open didn't necessarily mean you'd have the vein open at 1 month. And so when you start to think about the overall natural history and the open vein hypothesis we've talked about for literally 50 years, we actually learned quite a lot here that goes way beyond whether or not I should treat people with lysis, right? We know that lytic therapy showed that it results in more compressible veins and less residual clot at 1 month and actually at 1 year. And that we learned that, however, that venous non-compressibility, in other words, residual thrombus, was present in lots of veins during follow-up, even in people who got lysed. So 20% of common femorals were non-compressible and 50 to 60% of fem-pop veins were non-compressible. So what that means to me is that, excellent lysis doesn't guarantee a long-term open vein, right? And also we didn't reduce the rate of reflux. And that probably what undermined this study was subclinical recurrent thrombosis, And so now that tells us what's the next research direction. Well, clearly we have to figure out how we manage patients post-procedure with anticoagulation, right? And then I think that we have a better chance of seeing a better result in another study. And this is the progress of research and how it changes the direction of study. The rewards, I'm not going to harp on this too much, but the rewards have just been incredible. Somehow this trial, this little interventional radiology trial, managed to win a top 10 award from the Clinical Research Forum, which looks at all clinical studies, way beyond anything that we do in IR. Won a top 10 national award as one of the top 10 studies in 2008. We published lots of papers, obviously. The guidelines on DVT care, the National Institute of Care Excellence in England and the UK, the American Society of Hematology last year, and then the European Society of Vascular Surgeons now have guidelines that are all perfectly aligned in recommending that fem-pop patients should not be lysed, and iliofemoral patients, it would be reasonable to consider lysis in them. And this is a huge thing because you've got a surgical society here and the medical societies here, that are all finally in alignment. And that only really happened because of a large clinical trial that they had the chance to participate in. So the insights you gain from doing this kind of research are very important. So we need more investigator-initiated trials, and that means we need more investigators. I think that in SIR and the foundation, we talk a lot about infrastructure and for trials and all that, but honestly, the number one thing that we need more of in IR is more investigators, more trained investigators that can think along these lines. And that's important because most of the research we do is industry-sponsored research. And, industry-sponsored doesn't mean bad, but it's the questions that industry wants to ask. And those aren't always the most relevant and important questions for our patients, right? We need doctors to be deciding, and with patient input as well, what are the right questions to ask? And that really means investigator-initiated studies. The TRACT trial studied acute DVT, but really just one pivotal trial per decade is nowhere close to enough to really understand a disease process. We need to be doing a lot more, right? There's a lot that we can be doing at a national scale. I love the fact that more IRs, applicants and trainees are getting master's degrees and doing other kinds of research training and participating in programs such as these. I think it's just really wonderful, the transformation that I think is starting to happen. But I think it needs to go even further. I'll tell you a bit about a clinical trial I'm doing and propose that maybe you can help us transform the world starting here. Again, we're now looking at chronic DVT and established post-thrombotic syndrome. We know it affects patients' quality of life. There aren't randomized trials that have shown other therapies to help patients. Iliac vein stenting has been used for a long time, and it does seem to provide some improvement in our anecdotal experiences, but we don't have controlled studies to show that. Here's a patient who had a motor vehicle accident a few years ago with bilateral DVT, had a filter placed, and then ultimately thrombosed the filter 4 months later and presented with terrible leg swelling and pain, and continued having this kind of bilateral leg claudication and edema that was life-limiting, and it continued to kind of progress. You can see here we've done a venogram, and we have occlusion of both iliac veins, and these are just collaterals in the retroperitoneum. You can see there's a filter in here barely in the middle screen there that's occluded. You don't even see the IVC at all. We accessed the jugular vein and tried to get through and couldn't get through, came from the bottom femoral vein, couldn't get through, but we were able from each side to catheterize a circumaortic renal vein and was able to snare our guide wire within that circumaortic renal vein, pull it through, and then have through and through access, balloon up, and then place some stents here to open that vein up. And we can do these things and get good technical results. We've demonstrated that over the years. But I think there are some bigger questions. This is a hard case, and chronic occlusions are hard. Can most providers do this? Will the stent stay open? So far, the one-year patencies have been maybe only around 80%. There's payer concern about what's happening here, and I think the payer policies are starting to evolve in a direction that doesn't favor paying for stent procedures. And we know when you put in permanent devices in people and there are unknown complications down the road, that even as providers, we can be a target for litigation down the road, you know. So the C-TRACT trial is enrolling 374 patients. It's an NIH-sponsored multi-center randomized trial. I'm the PI for it. We have 30 sites around the country, and we're taking people with moderate or severe post-thrombotic syndrome, randomizing them to receive or not receive iliac vein stent placement, and everybody gets good post-thrombotic care otherwise, in other words, compression therapy, use of venoactive anti-inflammatory medications, review of their DVT care, and they're followed over a 2-year period with multiple outcome assessments. We're assessing whether the venous clinical severity improves, and we're also looking at quality of life, ulcer healing, safety, and costs. It's a great opportunity for patients, we think, because they get to work with multimodality PTS care teams and get broadly endorsed care, good care in the study. They get free stockings, they get some free ultrasounds and free clinical visits in some sites. They get the benefit of independent safety oversight from an IRB and a DSMB, and they have the opportunity to help others while getting excellent care. One of the challenges we're having, though, is that we've only been able to enroll about a quarter of the patients despite a couple of years of trying. And the key barriers we find in our IR community are, one, there are some people that are not totally comfortable randomizing people to not receive stents despite the fact that they're permanent devices with unknown long-term benefit and only an 80% patency at 1 year. And then we have a major cultural barrier, which is that unlike cardiologists and oncologists who routinely refer to other physicians for clinical trials, we don't really have that culture, you know? And I think that's going to be a big limiter if we don't get past that, you know? And I'm hoping that you and your generation can help us do that, right? We really need to get into this habit where when somebody comes in with a particular disease, we think, is there a trial available, and get that patient referred to that trial. For the C-TRACT trial, we've made that as easy as we can. We've even developed an app that any of you can download to your smartphone, and I hope you will, from your app store. Just type C-TRACT, and that enables you to very quickly refer patients to our clinical centers. You answer 3 HIPAA-compliant questions, provide a contact number for a provider or a provider surrogate, and then we will contact that number, get the patient information, and hook you up with the nearest clinical site. And so we are really trying hard, and we really hope that you maybe can even play a more active role in helping this happen. You know, I think in other areas we found that IR trainees can be a huge force in driving forward what we do in our field. I think PAD care is a great example of that, and there are many others. But I think the things that you can do is ask your attendings the hard questions in multiple disease areas that really push us to think that we really need to get the randomized trials and value them, right? It goes beyond even just my trial, but to many, many others where, you know, you're just taught that things work. And I think it's important for you to keep asking those questions so that people are motivated to go get the answers. I hope that you will try and create a local driving force among your attendings at your site to refer people with post-thrombotic syndrome to C-TRACT sites. We've made this painfully easy, you know, and we would really appreciate your help in doing that. And then really, for those of you who are social media minded, we are doing our best to work and collaborate with other organizations to try and get the word out, but we would love to enlist your skills in helping us with this. Many of you can run circles around us in terms of the ability to amplify on social media and get the word out there. We have to be a bit mindful because it's a regulated study, obviously. But having said that, we would love to have the help and the energy and the motivation if you're willing to provide it. So to conclude, I think that I hope that you'll take on this sort of investigator mindset of scholarship and objectivity and kind of curiosity. Take a disruptive mindset towards IR culture. You know, we need you to help push us to change, and you know, have that determination to do the work to really get these things done. So I will stop there and take any questions.
Thank you so much, Dr. Vedantham, for your incredible insight. I just wanted to double check if the Q&A is working.
Oh, let's see here. I'll look at the. I don't have a Q&A. I've got chat, but that's different. Let's see here. Hi.
That works as well, whichever, if you're able to see the questions.
Yeah, if people put them in the chat box, I ought to be able to see them. I don't see anything right now.
I wonder if maybe Ahmed can give some insight into that. I know sometimes it's disabled off to start, but if you have a few moments for quick questions or chat, that'd be great.
Yeah.
Yeah, I have it open right now. Questions at the moment.
Sure, yeah.
I guess we'll maybe give it a few more seconds if anybody has any questions. Well, I'm not sure if anybody has any questions. Ahmed, anything on your end?
There's nothing on our end.
Great.
Well,
Okay.
that was a really detailed talk. So, I appreciate the time, Dr. Vedantham. Thank you so much for really talking to us, trainees, and I know there's some attendings also in the audience. Really appreciated your insight into clinical trial research and also the time that you took out of your day to educate us on the level of investigation that happens at the top.
Great. My pleasure. Thanks very much.
Thank you so
Thank
much.
you, guys. Thank you again
Sure.
for all those who attended. Really appreciate it. Take care.
Take care.
Thank you.